Hello, 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 everyone, and welcome to another edition of What's Up, Doc. Today we have Dr. Thomas Hodgkiss. He is with Southern VIP. It is a vascular center that has branches in Tennessee, Kentucky, and Mississippi. You can go to southernvip.com to find out their specific locations. But just about every week, we like to have a doctor on because we have our network of 12,000 patients across the globe that have a lot of burning questions about peripheral artery disease, that poor circulation in mainly the legs. Dr. Hodgkiss has an expertise in PAD, but even more importantly, there are very few PAD specialists that truly specialize in PAD pain beyond just simply restoring blood flow in the arteries. A lot of times with patients with PAD, they end up getting treatment too late for a variety of reasons. Mainly, they were either misdiagnosed sooner versus later versus sooner, or they ended up with a doctor who said, I'm not going to treat you until you have a wound on your toe that won't heal. And meantime, all their tissue is just dying little by little. And by the time they get that blood flow restored, the damage has already been done to the nerves. So he specializes in some new treatments in regards to that to help patients a lot. But we want to welcome him. We want to get to your questions as well. So make sure to put them in our chat, whether it's in our comment section on YouTube, Facebook, Twitter, wherever you might be tuning in. Also, we do have a live studio audience who may be jumping in as well. Do make sure we have Josh, our YouTube producer, who is on standby waiting for your questions to come in for Dr. Hodgkiss. So get them in now, and don't forget to like this video and subscribe to our channel as well for more great content like this. And with all of that being said, welcome, Dr. Hodgkiss. Thank you for taking the time.
No, thanks for having me on. It's wonderful to be here.
So why don't we start with where your greatest passion lies when it comes to the treatment of PAD?
It's probably the easy answer is total care. And it's taking care of that patient from the day they walk into the door. I see a lot of clinics, they get the referral, they treat the blockage, and they send them back. And we don't do that. When that patient joins us, there's the vascular side of our clinics, and then there's the pain side. And so when you come in the door, it's where do you go if you have leg pain? And almost all we do a questionnaire risk assessment. If it's high, they automatically get an arterial ultrasound and TBI, toe brachial index. And if that's elevated, that to me, that's number one. That's so much more important than back pain, which I think they probably have. We go down the vascular side. And to me, you've got to restore blood flow to see how much relief you can get by doing that before you head down the pain treatments. And a lot of times you can intermingle the two as we go along, whichever becomes more expedient.
Do you get a lot of patients that are referred to you simply for diabetic neuropathy and they have never had a vascular evaluation? And you're sitting here going, whoa, 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 wait. Before we look at these additional pain treatments, let's just simply get you the TBI or the ABI or a leg artery ultrasound. Let's rule out the circulation issues.
Right. No, exactly. It's that's the first place we go is to evaluate the blood flow. And and it's amazing how everybody, I've got diabetic neuropathy, there's nothing I can do about it. I can take a gabapentin. And it's
Yep.
like, and then the next question is, has anybody looked at your blood flow? And then they tell you, well, I've got chronic renal disease and I used to smoke 40, a pack a day for 40 years, and right down the path you go. And they've got heart disease and that kind of thing. So we get that evaluation and then start to work it up. And yeah, the first thing, if it's abnormal, we markedly abnormal, and the patient is very symptomatic. The symptoms correlate with the findings on exam and on the ultrasound studies. And at that point, we'll go to treatment. So
Yeah. When it comes to the Global PAD Association, we have our Leg Saver hotline. And of the more than 1,000 tangible saves that we've had since inception in 2019, 35% the patients that called our hotline at 833 PAD legs, 35% were told that their amputation was being performed due to diabetes. Not one had a diagnosis of PAD prior to finding our hotline. And can you guess the percentage of those patients that actually proved to have PAD?
Oh, it'd
100%.
be close to 100%. Yeah.
100%. Every single one of those patients proved to have PAD, even though doctors said that the amputation was due to diabetes. The infection that you have, it's due to just diabetes. Now, that being said, it's not to say that there aren't instances where the amputation is due to diabetes, because I have had those situations. We do have patients that have come to us where literally they have fantastic flow going through the main arteries, and then it is those smaller capillaries that end up having the issue, and they end up with an infection to the bone, osteomyelitis, and that spreads, and they do need an amputation due to the diabetes. But in my experience, those are few and far between. What about you?
Right. No, it's so many of the people, they show up with that diagnosis and they get an ABI. It's normal. And nobody gets the TBI to check the flow from the ankle to the toe. And now with the loop procedures, and our big meetings in Nashville this week, and I was at dinner last night. I love the fact that so many of those guys are doing the loop. They're treating the distal arteries in the foot. And that's exciting because it just works. You've seen it, you know it. And the naysayers are the ones that have never done a loop, never treated the arteries in the feet. And so you go and you open up those arteries and you see how much relief they get. I'm astonished. I expect to come back and do, as we'll talk about later, so spinal cord stimulator, some kind of additional treatment. And I would say it's 10 to 20% that most of them get enough improvement. They're like, I'm fine. I'm not normal, but I'm so much better.
Yeah, we have so
So
many patients that they'll go in and they'll fix the iliac arteries in the abdomen. They'll go and fix, let's say, the SFA, the superficial femoral artery in the thigh, or the profunda, or the popliteal behind the knee, but then they don't get any further. Even some of the doctors that may treat those three tibial vessels that are located in the calf, they still will not touch that artery loop in the foot. And so patients will come to me later and they'll say, I don't understand. I had this procedure. They say I have great blood flow. Why is it that my feet still hurt? Why do my feet still burn?
and
Why
there's
is
nothing
that?
else you can do, right?
Right. And then they say there's nothing else you can do. You can walk, walk, walk. And when you can't walk anymore, we'll cut it off. And
Yeah,
that's the
yeah.
reality.
And the walking helps. That's an incredible thing to do. But it's getting to the doctors, there's so few still doing the loop. But it's growing, and I think there's hope for it. And like the research study we're doing, I'll get on, I get denials from insurance, and I will get on a peer to peer, and it's a vascular surgeon, and we get in this nice discussion. But usually the guys are reasonable, you know, and and they'll say, "We'll treat the AT and the PT." Well, I'm using the same tools to go all the way down to the foot, and so at least we can get on with the treatment.
And the interesting thing for patients to know is that the doctors that are doing the artery loop, when medically appropriate, especially if there is a wound that won't heal or rest pain that is waking the patient up at night because of a blockage down there in the pedal plantar loop in the foot, that artery loop in the foot, um, you don't get paid for going the extra mile. There is no reimbursement code that I'm aware of for the foot arteries. So at least if the insurance says, hey, you can treat the tibial vessels, then it's up to the doctor, these passionate doctors that will go the extra mile. And one of your counterparts, he's an interventional radiologist that's over in Venice, Florida. I won't name names. There's probably quite a few there, but there is one in particular that I got on the phone with, and this is how I discovered this, is he said, I said, how far do you go? I have a lot of patients around this area. And he says, well, we'll only go to the ankle and then we'll send them to vascular surgeons for amputation. And I said, I don't understand. He said, well, yeah, we don't get reimbursed for doing the foot, and it takes too much time. There's no money in it. and the hospital will not support us. Additionally, we had the same situation with another doctor over in Sarasota, Florida. And they said that they stopped doing limb salvage because it took too much time and there was no reimbursement for performing endovascular revascularization in the foot. And they made, I'm not kidding, I don't know. I must have this truth serum that people think they can tell me everything, things I don't want to hear. And then so the third part of it, he's like, and the hospital makes more money in less time with an amputation. And I am not kidding because I wanted to think so much that that was not the case, that no one was really in it for the money, that they really are looking for the patient's best interest at heart. But when I've had multiple doctors tell me personally,
Right,
I
right.
just, you can't look away. You can't look
It's
away.
it, yeah, yeah. I sat next to a guy last night. He's from Florida, and he said the reimbursement's awful down there compared to, here I'm in rural Kentucky, and our reimbursement's actually, decent. We can do it. But that being said, I'll schedule 4, maybe 5 cases a day because they do take longer versus my colleagues in Memphis that, they can put 10 stents in a day and they get paid the same for all 10 that I get paid 5. It is definitely a passion. And you've got to have the guy that wants to do it because I don't even think twice. If there's an occluded ATPT, my goal is to get all the way to the foot, at least get linear flow down there. But if I can get the loop, I know it's so much better. Just and then you see the result when you walk out of that procedure room and you just feel, and the patient tells you my foot feels so good. It's incredible, you know.
And so, what if these patients, you've restored their blood flow clear to their toes, and they are still experiencing pain? Also, conversely, and I don't know if it would be similar, for what about patients that end up with an amputation that might have that phantom pain? I don't know if
Right.
there's similar pain treatments that are available or if they would be different, but can you address both of those?
So when I first started doing or kind of got trapped into doing the pain side, I was like, these steroid shots are just so it works, and for a few weeks, then what? You just keep doing them, and I think that's a lot of the pain world. And so, and one thing that works well actually sometimes, and even with the limb is not there, but you treat it like it's there. I'll do a sympathetic block at L3 where that's where I put a needle next to the vertebral body, inject some steroids and bupivacaine, long acting novocaine, and they will get relief for a few months in the phantom limb. And there's no explanation for it. That's a simple thing to do. And a lot of times we'll do that sympathetic block to, someone's just miserable. They're new at the clinic. We can't get the more the involved procedures, the advanced procedures approved that quickly, and they're going to make us jump through the hoops and also, diagnose the things. So, it's somebody with the really bad peripheral neuropathy and the burning and the aching sensation down there. You go to the spinal cord stimulators are about the only option, but it's a really good option. And the nice thing is you test drive it. So it's an easy stick. It's like putting an epidural catheter in a pregnant lady, only it's a lead with electrodes on it, and you put in two left and right, and they can go up and down the spine to test and see if they can. So basically, what it's doing is blocking the pain signal from wherever as it travels back to the brain. Is the long goal. That's the traditional spinal cord stimulator. And a lot of Nevro's getting a lot of press right now, and that's a wonderful device. Boston, Abbott, and Medtronic are the other three. They're all good options. And in my older patients, I tend to put non-rechargeable because it's a hassle for them to charge the battery when you implant that. Just specifics. Nevro is a rechargeable system, and they'll struggle to do that. It's more powerful. But so you have that spinal cord stimulator. Do the trial. If it works, then you bring them back in a few weeks and you implant. And then it lasts indefinitely. And most patients Like during a trial, they'll say 75, 80, 90% relief. It's, you know, impressive the amount of relief they get. When you actually implant, I think, a year out, I'll talk to the patient and say, how's your stimulator doing? It's wonderful. And so, well, how much relief do you get? And almost all of them will say it's about 50%, which, I'm like, well, that's not any good. And they'll tell me, they'll go, no, 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 I can do things again. I can handle this pain. This is tolerable. So it's a very good option. And I've got patients 10 years out with stimulators, and you'll you'll
They
replace the
can last
battery
that
every.
long.
No, no, no. So typical battery, if it's a rechargeable system, yeah. And they'll last up to 10 years. A non-rechargeable, about 3 to 4 years. And so the nice thing nowadays, they can update the software in these batteries. So there's a new program, there's a new wavelength they can get. They can just Bluetooth to it and update it. And they're going to be able to do it over Wi-Fi soon, which is really cool. Neat stuff. They're pushing the envelope there. Um, but if let's say the battery goes dead, they get the new system, and the batteries are smaller and they're more powerful. And you can even change companies. I've got put in Abbott for a long time and switched to Boston. And the same patient in recovery with a Boston system will say, whoa, this is different, which is neat. It's just improved software. The leads are the same
So
in
what does
this.
that look like? I mean, just as you can remove, and I'm imagining now that you say the leads, now I'm thinking of the defibrillators that they place, and they
Mhm.
can be the leads can be removed, right?
Right.
On
Right.
like a
Yes.
defibrillator
Yes.
or but so
These are
on this
these look like
device,
these look like fishing lines, literally, with
oh
small,
wow.
metallic electrodes on the tip, and it transmits. So at the tip, there'll be 8 electrodes typically on each lead, and you put them up around T7, and I'll go higher if patients have back pain that's higher, obviously. But at T7, that's where you're going to catch almost everything from the legs and the pelvis. But those leads are the same. All 4 companies, you can just change. I've got a Nevro battery with Nevro leads, but now Boston's better. So I take out the Nevro battery, put a Boston system in, it can use their leads.
I mean, what does this process look like? What does the surgical procedure for this look like? I would imagine you can't just do it under twilight, or can you?
So literally I will do the trials. A lot of patients, I do it in a local, and I'm known, I numb like crazy. And I'm thinking, if I'm laying there, don't hurt me. And so I just really numb the tracks well with small needles. And so typically, though, patients will get a little bit of Versed and fentanyl, but I don't want them too sleepy, because once I get the leads in the epidural space, get them up where we think they should be, then we hook them up temporarily to the computer, and they're awake. And so the techs will test and make sure they'll make it tingle. When they initially started doing spinal cord stimulators, you would tingle. And so that actually feels good for a short period of time. You do that about 3 months. Most of the patients come in and they go, "You got to turn this thing off. I'm tired of tingling all night long." And but we'll make them tingle with the old system. It's a slower frequency, a slower drum beat, and you make sure they're tingling everywhere they hurt. And then they turn up the speed. So faster drum beat, faster frequency. They don't feel it, subsensory. And
So I
and
used
so
to
that's
hear that
just a needle stick.
I've heard that there are some drawbacks, to having these. What are in a sense, what are the contraindications? Are there any side effects? What is some of the skepticism, or what are some of the risks involved with these types of devices?
So it's always infection. This is in the epidural space and can be there forever. If they um so it's in infection. I'm sorry, I got a text there. They um I've got a patient in the emergency room. But
You're always welcome to pause to take a look at that
yeah,
as well,
it's a
because
colleague. Yeah, yeah, no, it's okay. It's
that's
okay.
always
So
important.
it's an infection. The leads migrate. And I've seen they break. I've seen car wrecks. Seatbelts have snap the leads in half. And so you do some repair work on those. If the leads, migrate to a different place, they can slide off to the side and all of a sudden they're shocking their chest wall. Cardiologists are a little bit afraid of them for some reason. It's the same technology they use and it only transmits a few millimeters. But for some reason, they'll tell patients don't get a spinal cord stimulator. And I don't quite understand that one. There's just not much drawbacks or contraindications. Sometimes you just can't get up there. But I've put these leads in patients with Harrington rods for scoliosis. I've found a gap and able to get it in there, and you get them this wonderful relief. Um, Drawback is it quit working. And sometimes with the Nevro system, it runs at such a high speed and frequency and power. I think they get tolerant to it. It never lets up. So the other companies will pulse. So they'll do a pulse in the spine every 90 seconds, every 3 minutes. And so I think in those systems, your body doesn't build the tolerance versus systems that stay on all the time. And the older systems did that. And so a lot of times after a year with a Nevro, they'll switch and then emulate Boston or Abbott. Um, so to put one in is not a big deal, and you can do that under conscious sedation. So the only difference is I make an incision, put anchors on the leads to hold them in, and the incisions maybe an inch long, and then maybe a couple inches to put the battery somewhere. Typically, we put it in the hip.
And we're generating a lot of questions here, generating
Okay.
electricity,
Okay.
generating a lot of questions here. So while you're looking at your text with your patient in the emergency room here, why don't we jump to some questions that are in regards to these spinal simulators? First, let's go to Marcia Burr. Marcia Burr, go ahead and unmute and ask it looks like you have two questions.
Okay.
Yes, I'm very interested in this episode that you're doing today. I've been looking into spinal cord stimulators and DRGs as well. So my first question is about how effective do you think the DRG procedure is? And also then I also have critical regional pain syndrome. So how effective is this for CRIPS?
It's I love DRG. And so it takes a higher level of skill. And the nice thing is, like, as an interventional radiologist, I deal with catheters and wires all day long versus pain doctors. They do it for this procedure only. And the tools to me are like stuff I was using 30 years ago. So if I do a DRG and I'm struggling with the tools they give me, I'll literally use my wires and catheters that I use to open up arteries to get to these places. But DRG is wonderful. So, and I was going to go there actually. So, say you have pain that's in your foot. It's the outside of your foot across the top of your foot. That's the L5S1 nerve. So two nerves. And so you literally put leads in your tailbone and one at the lower spine where those nerves come into the spinal cord. So instead of blocking the whole spinal cord up near T7, this is more specific, which makes it work better and can almost completely shut down the pain there, as long as it's the L5S1 nerve, those two nerves. So those are neat. A lot of times you find out, well, I've got L4 as well, and the batteries can only insurance will pay for 4 leads. So you got the same thing on the other side. You got to kind of pick and choose. Hopefully that helps you. Um, CRPS is I have probably my biggest success stories with that is more of a traditional because it winds up being, say, a whole leg, the whole left side of your body. And so one of my best patients, I mean, when I first saw him, he looked like Popeye it was the right side of his body. And everything swollen, everything edema, and I shook his hand, his right hand, and it literally almost brought him to tears. But we wound up putting in spinal cord stimulator in his cervical area, which got his arm and shoulder, and a second one for his leg. And so now the limbs are the same size. He still hurts, but it's so much more tolerable.
Great. I was like 2 days out from being scheduled for a DRG placement, and the doctor in where I live actually did the very first DRG placement years ago in Gainesville, Florida. His name's Dr. AJ Anthony. And 2 days out from the procedure, they stopped and said, nope, can't do it because you can't be off of your Plavix for 8 or 10 days. And so what are your thoughts in this regard? Why the long break in taking Plavix?
How long? Yeah, it drives you nuts because the official rules are, 5 days at least of Plavix. Um, I mean, it's a good question because you have to think about the fact we're using needles, and if we got a bleed in the spinal canal, you can cause paralysis. And I think it's a very low risk in the right hands, in a person like him. So they were saying 7 days off your Plavix. What
Eight.
about going to the hospital 10 days?
8 to 10 is what Dr. Anthony told me, 8 to 10. So then he
I
came
wonder
back
what
and
he,
told me a T-spine stimulator that I could be off of it for 8 days. And still my interventional cardiologist said, no, the longest you can be off it is 5. But then I had an amputation and I was off of it for more than 7 days. So, I'm confused a little bit about these nebulous guidelines.
Yes. Okay, thank
right,
you,
right.
Marcia. And so just why do you in general? I don't, for that's a long period of time. I haven't heard that for spine simulators. That seems extreme. How long did you say that you keep your patients off of their blood thinners prior to a placement?
It's if I'm going to do the actual implant, I kind of like 3 days because, at 3 days, half the platelets have replaced themselves. And that's IR versus pain. I know my pain guys, the two guys that work with me, no way they would do that. And we have issues about that. But I think you use safely, especially a traditional spinal cord stimulator. Um, 5 days would be more than enough.
And how often do you, for patients especially that have genetic, clotting disorders such as factor 11, factor 5, whatever it might be, do you offer a Levinox bridge injection?
Right. No,
Is that
I
an
would.
option?
Yes. I think that's definitely an option. Um, and I'm surprised that they didn't bring that up with Marcia.
Yeah. Well, thank you for that. Okay, let's move on to Kathy. Kathy, go ahead and unmute and ask for Dr. Hodgkiss your question.
Hi there. I was just wondering about, is this technology a kind of like the big brother of a TENS machine that you
That
would
it's
apply,
it's funny. I'm sorry, Kathy, were you?
that you would apply it externally? We in the UK, I was on a trial where they were using TENS machines externally applied to help with walking
Right,
pain, which did help.
right. No, it's yeah, I think you can do both. TENS is it's a completely different system. So that's the pads and they stimulate muscle
Yeah.
contraction versus it's almost like a pacemaker. I call it a pacemaker for your back. And so these leads pulse into the spinal cord and block nerve signals from reaching the brain.
Well, these ones were actually applied straight to the calves.
So TENS and spinal cord stimulators are really different.
Yeah, right. Okay.
Does that
Fine.
help you?
Yeah, that's fine.
Okay.
Well,
And I have it's actually interesting because over at your organization, you have a nurse practitioner, John, that's really big into walking programs. And they had done a study that Kathy was participating in that she was addressing. One of our lead advisors is a walking therapy researcher over in Glasgow, Scotland, and he's world renowned. And he had been doing quite a bit of research over there about the impact of offering these patients with claudication a TENS device to take with them. Of course, at first, long ago, where they have all the cords hanging down and everything else. Well, now you have some ones that are easier to walk with fewer cords. But they would have them walk with them, and the TENS would offer just enough of a distraction
Uh-huh.
to the claudication that they could walk further and faster, right, Kathy?
They were putting them on the legs, the
They
pads.
were putting them on the, yeah.
The legs. Put
Oh,
them
that's
on the,
cool. I
and
love it.
it worked. And then eventually I just took them off and then I just walked the same distance anyway. So it got me from the point of where I was in a kind of low pain place to being tolerable. And they've done a lot of trials on them. Quite a few places have done them because there's very little else to offer. Really, you have to self-manage this thing. There isn't anything. There's not offered anything. They have this method that they call usual care. Usual care is take meds and walk.
So, Kathy, the way he explained it, the way Dr. Christine explained it is that the TENS unit doesn't take away the pain. It offers a distraction to the pain, right?
Yeah, it's like it does do a buzz, a bit like the Revitive, but Revitive, you sit in a chair with your feet on the thing. This buzzes as you're walking, and they set it up to a certain pattern. The trials they did had placebo and the pattern, but as I didn't actually qualify to do the trial because the biggest single thing that took you out was that you needed to walk the same distance twice. Well, that ruled out about 90% of people who went for the initial, obviously. So, but then when I asked Chrissy's colleague to just give me the formula that I'd bought my own, he gave it to me and we set mine up the same and it worked. But then I ended up on the research group, although I hadn't used it other than personally, just on the fact that walking helped. Walking helped. So how much of the walking it was as opposed to the TENS, we don't know.
Yeah. Thank you, Kathy. I just thought that was interesting and something that we should probably bring to John. It might be fun to do a research study here, in partnership to see if it's something that they should be offering here for patients. But every time Dr. Seenan comes on and talks about it, we get a flood of messages. Which one should we get from Amazon? Everyone is so excited.
Right. Well, I mean, it's ubiquitous and it's inexpensive. It's wonderful.
Right. Exactly. And we have a question coming in from Mike over in Canada, who is from the UK. I think Mike posted a picture in our chat of his toes, and he wanted to ask a question about what he's been experiencing because Mike, his mom had an amputation at one point, and he is concerned that he might be on the same path. So every little thing is really raising red flags for him. So he'd like to have a moment with you.
Yeah, thanks for that, Kim. What it is when I was diagnosed in February, my vascular doctor did say that it was minor vascular disease with mild claudication. Now, he actually discharged me with a 75% blockage in my superficial femoral artery, and just said that conservative exercise, healthy diet, quit smoking and drinking, all the things that you should do anyway. Now, I've been walking every single day. I go on my treadmill every single day, and I'm not really getting the claudication pain unless I really go on an incline now. But I've been getting this. He also said that I could have the start of Raynaud's because the bottom soles of my feet were going a little bit white and cold. It was like blocks of ice. Now I was getting a white tip every time my feet were going cold. The end of my big toe was getting like a white circle on it. It still happens, but now once the blood comes back, it's getting like a purple ring around where the white usually goes. And I'm just concerned that it's progressing a little bit more. I'm moving my toes.
You can move your toes, okay?
Yes, yeah. I'm doing loads of walking as well every day. It's not really affecting my walking until I get to around the hour and a half mark. It starts irritating, which it would do anyway. But yeah, I'm just concerned about this darker purple area that's coming now. Whether it could be nerve damage or whether it could be the start of CLI. And I'm just getting a little bit freaked out, to be honest.
It would the first thing I'd want to do is know the TBI. Mike, have you had an ultrasound or a TBI recently, or do they do that? Do you have access?
They don't usually do TBIs. They have just general ABI.
Yeah, we did it. They did an ABI, and that's when they found out that my leg was 0.68 on my left leg. My right leg was over 1, so he wasn't concerned about that because I've got the pulses, and I can still feel pulses myself. Now I do get slight pulses in my foot and my ankle on the left. I can still feel them, and in my groin. Sorry, I've lost where I was going with
The
that.
the
No,
left
but
side was
left side's worse.
0.68, Mike.
Yeah.
Yeah, so they went ahead and did an ultrasound. When I went to go and see the vascular doctor, he sent me in for a scan, and they found a 75% blockage in my superficial artery. But then he said it was clear. It was clear after that. So he wasn't really concerned. He just discharged me back to my GP with conservative therapy, really.
But how
Are
does
you
it
diabetic?
become, unless it's clot, and then they put you on blood thinners, and that's what gets me, is that where is the advance when someone presents with PAD? Yes, you might have some atherosclerosis, which makes it, PAD versus simply someone being hypercoagulable. But you can have both. And my issue is, why are a lot of doctors not performing additional blood work? It should be standard protocol, don't you think, for clotting issues if someone has PAD? I just, if there's any potential presence of thrombus or clot, why not? Before
Right,
He
you
did.
right,
discharge them. I mean, it's
Yeah,
75% blocked, but then suddenly there's nothing there. How?
right,
yeah.
right.
He
And
said
you
that it was clear after that. He
are
did put
you
me on a
taking?
statin. He put me on a statin, and he put me on a toravastatin.
Okay,
He put me on Ramipril for my blood pressure to bring my blood pressure down. But I think my blood pressure was high because I've got white coat syndrome as well. So every time, obviously, yeah, and so he put me on a statin, and he put me on an aspirin, a low dose aspirin. So I am on the
good.
blood thinner and the blood pressure tablet and the statin. But I just feel as though it's progressing, and I'm just worried. That's all.
When was the ultrasound? Has it been a minute?
It was February 13th. So
Okay, so
six weeks ago.
recent,
Yeah.
right? Um, it's I would worry. Are you diabetic?
No,
Okay, good. And not pre-diabetic.
not that I know of.
Smoke?
No,
You
I
smoke?
used to be. I used to be. I quit
Okay,
the day that I quit the day that I walked out that hospital from the vascular surgeon.
that's great. No, that's key. Um, it worries me. Just I'm looking at the nails too. The discoloration goes along with, not great blood supply down there. And I mean, they're red. When it's on your toe, does it blush back? The
Yeah,
capillary refill.
once it's filled with blood and it's red, I do have the capillary refill. It comes back within seconds. Um,
Good, good.
but
Okay.
when my feet are cold, like if we've been for a walk outside or something, my feet go really pale.
Mhm. I mean,
So
it
that
could, it would be unlikely to be Renault's, but possible. Never say never. Um, but never had this till recently, right?
no, I've had the claudication for about 12 months. So it started probably early last year, and I was just putting it down to me. I was doing a lot on the treadmill and doing a lot of working out at the time. And then when I started getting the pain and stuff, I eased off, and I thought, right, I need to get this seen to. And that's when my last visit to
Right.
the UK, I managed to get into the doctor. Um,
Um, it'd be interesting to get the toe brachial index because we're not measuring blood flow. We're measuring to the ankle, and even the ultrasound goes to the ankle. Did they look on the top of your foot by chance with the ultrasound? Do
yeah,
you remember?
yes, I think so. Yeah, yeah,
And then that looked good there.
yeah. It's I'd have to look into the. Sorry, I don't know where you've gone now. Sorry. I'd have to look into the results that came, but the doctor did say that they weren't concerned about they weren't concerned about my symptoms, and with it being a 75% narrowing, and with me having pulses and stuff, they weren't prepared to intervene with that. They said that if they did anything, it could possibly make it worse.
No, and if the claudication's gone away with the walking, that's wonderful. I mean, it is. It's just these toes worry me. I just, I would want to know what's the blood pressure in your big toe compared to your arm. And maybe you can find that over there in UK. It's not that expensive a machine, and maybe someone does that. You might have to pay cash to get it, but it's not, it's a blood pressure cuff. So it's
Yeah,
not an expensive.
because I'm not actually back in the UK till June. So I
Okay.
was actually, when I messaged Kim today, I was actually thinking about getting a last minute flight at the weekend to go back to Manchester and go and get things sorted. But if I can hold off for as long as I can, it'd be a
I,
advantage to stay in Canada.
I think you're safe to wait, Mike. If obviously it progresses, you want to do something about it right away. But you're in Canada right now?
Yes, yeah, till
I
June.
wonder, I mean, like down in the United States, you can just go and there's labs that do screening, and you can find a machine that somebody's got a TBI, that machine, and it probably wouldn't be that much.
Mm,
Yeah, if he could just get across the border, we could get him in, and then the Way to My Heart or a
Yeah.
Global PAD Association would actually help cover it for you. But over there in Canada, unfortunately, I mean, if he could get to Sunnybrook over in Toronto, that's another place that we can get you in right away. They are the only um, actually designated limb salvage center in Canada, and so they're great, and they get everyone in if they can get a referral to that. But if you
I
can
have,
wait, that would
yeah.
be the best.
Yeah, I have found a vascular doctor in the Moncton area of New Brunswick, but I'm not too sure. I think but patients can do self-referrals to his clinic as well. So I'm thinking
Well,
that
it's worth it.
if it does progress anymore and I start getting worried
Yeah.
more,
Yeah.
then
No, that's a
then
that's a
my
great
partner will
option,
take
Mike.
me. Yeah, my partner will take me. I don't mind paying for the treatment. And just one last thing: does pads cause nerve damage? Then could it be nerve damage? Because my toe just kind of it twitches as well every now and again.
It can. It's so when you've got poor blood flow, its tissues are dying. So that's muscle, that's nails, that's nerves. It can hurt everything.
Right. Okay.
And then again, the more you walk, the more you stimulate the blood flow, grow the small vessels to get to enlarge.
Hmm.
But it sure can. I think I'm surprised at how much is reversible when we revascularize down there. I'm seeing patients, they'll come back and first thing you do is show me how they can wiggle their toes and the sensation. Their balance is better. Things I never even thought about.
Hmm.
I was just being a plumber. So
Yeah.
Thank you. Thank you so much,
So
Dr.
yes,
Hotchkiss. And thank you,
thank you,
Mike.
doctor. Thank you,
And
thank
I
you.
you're
want
welcome.
to bring in Heinz, because this is a question that we like to ask actually all the interventional radiologists, right, Heinz, about what are your tips and tricks for those patients that have radiation damage to their leg arteries and having to contend with lack of blood flow due to that?
Both directions,
Wow, that
right? Not just arteries, but you got veins involved.
oh yeah, that's some serious scar tissue. I was in the cancer world 15 years and we saw that. I mean, you could do the traditional stuff. It makes you think about would lithotripsy or lasers help crack this scar? And I'm seeing that in the calcified vessels. And now we're able to take lithotripsy all the way to the loop. Um, that would be interesting in a scar fellows. Probably won't do much for veins. I'm not sure what, you just develop the collateral flow. Is it leg radiation to leg?
Yeah, in the SFA and knee area. Well, I shouldn't say SFA, the thigh and knee area. So
Sure.
yeah.
And so what are the arterial studies, your ultrasound and that, is it showing any blockage or?
Oh yeah, and I've been treated. I've had at first a balloon, then I went from balloon to balloon and stent, then I went from balloon and stent to balloon and an additional stent and atherectomy. And after 2 years now, my additional stent is clogging up again. I've also had Varithines. I've had sound waves in that to close veins off so they would flow the nice direction.
Right.
Um, yeah, I got a very good doctor that's taking care of me, but and I'm walking every day. I walk 4 or 5 miles every day. So
no, that's great. That's great.
What
does so when he did an atherectomy, what do you know what he used? Was it rotational? A drill?
It was a laser.
Oh, was.
Yeah, the first
when
the first doctor I went to, he did I think it was a Roto-X or something like that. And then
Rotor-X.
The last one did the laser.
how long ago was that?
It was February 15th of 2023.
Okay. They just came out with a new, it's 1.7 millimeter laser that's so powerful. And so I was leaning more towards lithotripsy before, which just came out for, SFH. Most of the time we've been doing lithotripsy above the groin. Now they can go the other way. And, it's using sound waves I wonder how effective it would be in the scar tissue.
Yeah.
And like this big laser, when I'm treating stents now that are occluded or full of debris, I go right to the laser. I don't, because the rotational things will get hung up in the stents but this new laser, he's probably using Orion angiodynamics, I'll bet, and he would have access to that.
I'm thinking he would too. With that, I'm fine. I walk with a little bit of claudication, but it's not forcing me to stop. And I pick his brain every time I see him about PTAP. So that may be down the road, PTAP. It may not be. I don't know, but
yeah, I mean, bypassing it.
Yeah, I'm a perfect candidate for it.
Yeah, you're right.
So
Don't
for
let
people
him
who don't know
stitch.
the PTAB, Dr. Hodgkiss, have you tried the PTAB yet? The detour system, so the minimally invasive, you can do it. You can do your own bypass, just hijacking a vein from the SFA, the thigh, and rerouting blood flow to the popliteal or behind the knee. I've even seen, I know it wasn't indicated for it, but you know how it is, Doc. If you can do it, it's off label, but I've seen it even be used and reroute blood flow clear into the tibial. I've even seen this PTAB or the detour system. When they say they can't do a regular bypass because someone jailed the entire artery? Well, you can actually go through the stent into the vein, from the artery to the vein, and actually reroute blood flow. It's pretty remarkable. I even saw in the last procedure I was at with Dr. James Joy that invented it. I was down at his place over in California, and he ended up going through a bypass graft and rerouting blood flow around that. Now, the only thing with that is what's in a bypass graft? Clots. So there were some situations that he wished he would have mitigated ahead of time and prepared for, but that is going to be a part of his next publication to talk about that for those who use PTAB.
No, I will be doing that because it's a wonderful option when that's all you've got left, and that would be pretty neat to do without having to have surgery. The tradition.
Yeah, if you haven't been in touch with those folks, I'll get you in touch. I'll do an intro because that is something you would have a lot of fun with. And I don't think there's anyone.
That's not reflow. I was thinking that's the
Endologics.
Yep.
Endologics. Yeah. I think that Jacqueline Majors, who was our U.S. Vascular Surgeon of the Year, who speaks very highly of you. I know you work very closely together on a lot of fronts.
She's great.
Yeah, I think that she's getting involved in it. So that might be something that
we
talk to her about.
I gotta pick her brain about it.
But I'm curious, you were mentioning sound waves, and then I'll just have 3 more questions that we ask every doctor. So I apologize for we're over the hour here, but iliac artery endofibrosis, we just had a professional cyclist that there was an article done on him and how they're having to do a procedure because he ended up, a lot of endurance runners or cyclists get this from repetitive movement. And so the patients were asking about what is this? And I was also thinking, well, why couldn't shockwave or another lithotripsy device work in a situation like that versus having to do something invasive?
Right. No, I think that we don't know at this point how it does in scar tissue, but it makes sense that it would crack the scar tissue just like it does calcium. If it's going to break calcium, it ought to break that. And that's, bypassing the celiac or endarterectomy on celiac is a big deal versus, just running up there and putting the the shockwave balloon in. That's a neat option.
Okay, so our final three questions we ask every doctor. We have our sponsorship. You mentioned Reflow Medical with their retractable stent that they're coming out with, possibly waiting for FDA clearance maybe in the next few months. I know they have CE mark already, but have halted distribution until they get the CE mark here in the United States. But they're sponsoring this series of videos. The first one is what we call the Pulse series. And we have doctors sharing a case they learned the most from. It could be a success or it might have been a failure, but it is a case that not only you learned from, but others can still learn from.
So you want one that I learned from? No, it's so when the VBAC came out, it's the guided needle that's out there now. It's a wonderful thing to have. And I've got a couple gentlemen with these stents that have been included for probably 10 years. And I could get in both ends of the stent, but I couldn't get all the way through it. And so the VBAC came out and I thought, oh, this is it. And so I get up there to where I got stuck and you start to push this thing. And after about an hour and I've gone about this far, I gave up. And at that time, I put the new big laser in there. I was like, I was going to laser the lower stent anyway. I said, I'm just going to run it up there. So no wire. And it went through it in like 10 seconds. It was wonderful. And so now it's like when I get stent, like with Mr. Hines, that when I've got intimal hyperplasia or build up inside stents, I'm going with this big laser. It's incredible how it just cracks that hyperplasia. So that's been a nice thing.
I love that. Okay. Tell us about a patient that you still shake your head to this day that you cannot believe that they were not diagnosed sooner. And it took coming to you to actually get the right diagnosis and the treatment they need. And I know you have a million of them. It's probably hard to do one, but this series is geared towards, this one's actually sponsored by Biomedics and they have a testing device called PadNet. But the reason we're doing this is because we want to put the headlines out there for a patient to say, were you diagnosed with gout? It could be your arteries. Were you diagnosed with a back issue and treatments didn't solve your problem? It could be peripheral artery disease. So kind of think along those lines. And as you tell us the story of a patient, their journey to diagnosis.
Obviously, from the pain side, it drives me nuts because I'm doing epidurals, steroid shots on the nerves all the time for leg pain. And when I talk to the patient, classic claudication. The patient that was misdiagnosed is any patient walks in the clinic and they're amputated. What happened? And so this lady came to me and she's a kidney renal dialysis patient, had fluid in her lungs. So she let me draw the fluid off, just thoracentesis, no big deal. And the sweetest person you'll ever know. And amputee. I said, what happened? And she said, I got an infection. They had to cut it off. And I said, really? I said, well, how's your other leg doing? And, she's got pants on and stuff like that. She said, not good. It's weeping. I've got blisters, that kind of thing. And I said, did anybody do a vascular workup? And it's classic. Of course not. Just cut it off, problem solved. So we did ultrasound. Of course, she had blockage from groin to her toe, got her open and saw her today actually. And she's just wonderful. The change in psyche, they feel better. They don't have these chronic infections. She's actually using her prosthesis on the other side now. Just the neatest thing ever.
What a great story. And then I'm sorry, we have just two quick questions coming in before I get to my final fun one for you.
Okay.
Kathy is saying that Natalie in the UK has a question about why the soles of her feet hurt more in warm weather than in cold weather. Usually I hear the opposite when it comes to peripheral artery disease. So that one's perplexing.
You may have, all I can think of there is neuropathy. No pain during cold weather, or is it both?
Sounds like it's just more prevalent to her in the warm weather
That,
versus cold.
in that situation, I might think more of a neuropathy, not from vascular. And, maybe low dose gabapentin there, it'd be wonderful. It's amazing how good that drug is at low doses. I hate it at high doses.
Do you ever use B vitamins to help those patients with
Yeah. Yeah.
neuropathy?
Well,
Can
John,
you?
John, he's all over that, and I love it because it just makes sense. I absolutely do it.
They just put my dad on Metanix, which I didn't know there was such thing as a prescription strength B vitamin, and it's been incredible for
Oh,
him.
wow. Yeah.
And so you can't really, it's not covered by most insurance. And so we had to go through brand something direct down in Florida to get it at a lower price. It's available at $200 a month here in most pharmacies. And we were able to get it for $60 a month, which is still really
Oh, that's
expensive
great.
from something brand direct over in Florida, and they
Uh-huh.
ship it to you. But I just thought it was interesting. Is there any, when your nurse practitioner, John, um, tells patients to start a B vitamin, do you know what B vitamins he tells them to get? Is it just a methylated liposomal B complex, or are there particular B vitamins like B17, B12, B6?
He's got like a regimen, and I wish he would have. I just left him, but
We'll get
we need
him.
to have him on. Yeah,
We'll get him. We're
we'll
going to
set
get
him
him.
up.
I actually am mentioning
Good.
him. I don't know if you heard, but my first publication is going to come out in Wounds Canada in May, June, and I gave him a
Oh,
shout
that's
out
awesome.
for his how he and I had talked about the foot cycle and how big of a difference it can make for patients that have wounds to improve their circulation and their prognosis. So he got a little bit of a plug in that article,
Oh, that's
which we'll
great.
see
That's
soon. So
great.
we'll have to have him on then. And
Yes.
Marcia, did you have a question? Marcia O, did you have a question?
Yes, hi. I don't know where I went though. I'm sorry, I've messed oh, there we go.
That's okay. We're looking at really interesting puzzles on the floor. You must have
we're doing puzzles.
framework.
Oh, no. Anyway, it doesn't matter. My question was about general pain. Like, why is it sometimes I have really, really bad claudication and other times, sorry if I'm sideways, I don't know what I'm doing here. And other times I don't. And are there any quick, easy fixes for claudication to help you keep walking through it?
So it's leg pain.
Yeah, calf pain.
Yeah. Well, I think the minerals. The first thing I go to, my dad will do that, and so I get him kids chewable magnesium and calcium, and those can help relax those muscles, and it
Really?
works so fast. Yeah.
So
The
like if I'm going
chewables,
to go out on a hike, take that first, maybe?
yeah, I think it may work, may not. And potassium is another one, but magnesium and calcium seems to really help with the cramping and really get those muscles to relax. And that's what magnesium and calcium do.
Can you take that every day?
Yes, sure
Thank
can.
you.
It'd be nice to know where your magnesium level is. It's probably, I think everybody's low. It's like vitamin D. The whole world's
Really?
low on vitamin D. Yeah.
Yeah, they say that there are three main reasons for chronic disease, and it's lack of magnesium, lack of oxygen, and lack of water. So
Yeah. Yeah. That
And
sums
that
it
is
up.
definitely one of them.
Kim, that you brought up water. I've been trying so hard to increase my water content. And does water have, blood is probably part water, right? Like what role does being hydrated have in lessening, either increasing blood flow or lessening pain? Or is there any connection?
Well, we started easy on you, Dr. Hodgkiss. Now,
Well, the minute I think about it, someone dehydrated, blood pressure's low, they're getting less blood flow to their limbs. It's a little bit of a common sense thing. And then
Yeah.
when you hydrate, I almost think I was reading some articles about the fact that we drink empty water, whereas like if you drink well water that's safe, you get all those minerals in it. So, it makes me think about drinking, what is it? The Fiji water, something cheap, but you don't have to drink that stuff's expensive. But drink water that's straight out of a spring that still has the minerals in it. So then you get magnesium, that's another
Oh,
source to get it, maybe not enough.
and I'm on a well, so that's interesting. And I'm always trying to
Yeah,
clean it up. Maybe I should just let it
right.
be. Interesting.
You kind
Thank
of
you.
wonder what it is. I grew up on one. So,
And you're still alive.
yep, made it.
Thank you.
So, and it's good to see that Marcia Burr is also drinking her water mixed with Juven. So that's really great for wound healing as well. We're big proponents of Juven. And so for many patients who can't afford it as well, we try to get them, some additional packets that we can help with. But final question, because you got to go save those piggies. And I know you have a patient also in the emergency room. You probably got to get on the phone with the other
Yes.
doctor.
Yeah,
But
I go get
this
number
one
at the
is
moment.
a really fun question for you.
I
Let
had
me
my
just
camera off. I
mute
told I can't hear you.
Marcia really quick. There we go. But our fun question is a thinking one, and it is actually related, of course, to Reflow Medical, because Reflow Medical, with its new retractable stent, the whole idea is you got to leave that retractable stent up for about 6 minutes. And that's a long time in cath lab time, right? A lot longer
Right.
than you would a typical balloon to dilate the vessel. And so I came up with the idea of, when I was at Forbes magazine, I would always ask every executive, what are the 10 minutes that mattered in your career? There's always a moment, a conversation, a scene in a movie, a television show, something you saw, some conversation you had that became a real big catalyst in your life, whether it was for your career or your personal life or some direction. And so for you, I'm curious, what were the 6 minutes that mattered in your life or your career that helped become a defining moment for you and who you are
Mm.
today?
Yeah, you got me thinking there. I grew up in a Catholic boys' school, and all I can go back, they pounded us the whole time, but I always think about, you perform like you look. If I look sloppy, feel bad, I'm not going to perform well. So I don't know if I can come up with anything better than that short term.
That's actually really interesting that you said that, because there was a doctor. I love Dr. Farco. He's I think he's North Carolina. I think. Anyway, he was saying that his healthcare system sent them a note today saying that all of the employees, when they're front facing with patients, they now have to always have their lab coats on with their name, with the name of the facility. And there were a lot of employees that, particularly the doctors and clinicians, that were saying, whoa, wait a minute. I mean, what if we come out of the OR, whatever it might be, we have to go find our, take off our stuff, from scrub it in, and then try and find our lab coat before we go talk to the patient. But that's the case. So the idea behind it is, how you look, how you present is how you're received.
Professional. Right. Right. I agree.
So thank you so much. I appreciate your time. Any final thoughts before we head out and let you be on your merry way? We appreciate you so much for taking so much
No,
time with us.
no, I appreciate you guys, and thanks for love talking to patients, and